I'm very fortunate to be here on this podium to be talking on this very important topic, often neglected. I'll be discussing this topic under the following headings. First, I'll start with anatomy and physiology, how it's different from the left ventricle, causes of the common causes that we encounter in critical care that lead to RV dysfunction, what are the clinical manifestations, physical findings, diagnosis, and briefly about management. So, right ventricle anatomy is very different from the left ventricle. It is structurally, geometrically, and mechanically very distinct. And the response to disease states is quite different. And the general assumption is that the therapies that improve cardiac performance are equally applicable to both RV and LV, which is only partially true. So let's look at the anatomy. Right ventricle sits in the anterior thoracic cavity right behind the sternum. It is crescentic shaped in cross-sectional view and triangular in longitudinal view. So it is a very thin, pliable structure made up of only two layers of muscle fibers, and it is about only 1/5. It has got only 1/5 thickness as the left ventricular myocardium, and it pumps blood into comparatively a low resistance circuit, which is the pulmonary circulation, and it nearly handles the same cardiac output as the left ventricle. So, because of the structure of the RV, it is very suitable to handle volume very well. But the same structure puts the RV at a disadvantage to handle pressure or the afterload. So these are the main differences. As I discussed, the vasculature, it pumps blood into pulmonary vasculature, which is very thin walled. They are large in diameter. It's a low resistance, high capacitance circuit. The myocardium, as discussed, thin and compliant. It adapts to preload very well because of the structure. And the blood supply. So it has got dual blood supply with RCA and LAD. RCA supplies the free wall and the posterior two-thirds of the interventricular septum. And the LAD supplies apex and the anterior one-third of the interventricular septum. The good thing about the RV is that it gets blood supply both during the systole and diastole, unless it's in patients where RV is significantly hypertrophied or where the pressures are quite high. During only those states, the RV gets its blood supply during systole. And it is resistant to ischemic injury because of this dual blood supply and also because of the low oxygen consumption rate. And it also has got significant networking. So we can see in this diagram that the right ventricular doesn't handle the pressure very well. You can see relative change in pressure from 20 to 30, the stroke volume significantly drops. When you compare with the left ventricle, it handles pressure quite well. So next, moving on to the topic called as ventricular interdependence. Since the right ventricle and the left ventricle are enclosed in a pericardium and they also share the septum, okay, because of this anatomical feature, both of the ventricles are dependent on each other. The size, shape and compliance of one ventricle affects other ventricle. Physiologically, you can see this. During inspiration, the preload to the right ventricular is high. At the same time, the left ventricle preload decreases because of the expansion of the pulmonary vessels during inspiratory phase. The exact opposite thing happens during the expiratory phase. This is what we can see in the physiological interventricular dependence. So we can divide this into two, that is the systolic ventricular interdependence and the diastolic ventricular dependence. So because of the shared septum, about 40% of the RV systolic function is contributed by left ventricle. And coming to the diastolic ventricular interdependence, it is characterized, you can see this classically in high afterload or high preload states. The shift of the interventricular septum puts the left ventricle at a disadvantage and decreases the cardiac output. So we can classically see this here. In fluid overload states, the right ventricle is dilated, it shifts the septum towards the LV. It increases the right ventricular and diastolic pressure, causes tricuspid regurgitation, and there is shifting of the septum, putting the LV at disadvantage, decreases the LV preload and consequently decreases the cardiac output. So if you remove some fluid, right ventricular endosteric pressure decreases, tricuspid regurgitation decreases, septum will shift back, and the cardiac output will improve eventually. So, what is the definition of RV failure? RV failure it can be theoretically defined as an altered structure because of hypertrophy or dilatation and impaired function of the right ventricle, resulting in failure to maintain enough blood to the pulmonary circulation and eventually leading to underfilled left ventricles. So coming to the pathophysiology. So as I discussed earlier, the right ventricle doesn't handle pressure very well. So whenever there is increase in afterload, RV dilates. Okay, it leads to failure of the right ventricle. But if there is a slow increase in the afterload, as in patients with COPD, RV can adapt. So how it adapts? Initially it dilates. It dilates to accommodate more volume so that preload increases to compensate for the change in pressure. Okay. So subsequently there will be left first shift of the LV septum, resulting in loss of assistance of the LV. It decreases the RV output. That eventually decreases the LV preload. Subsequently, because of the dilatation again, the tricuspid regurgitation increases. This increased tricuspid regurgitation will lead to decreased forward flow, leads to decreased cardiac output from the RV, leads to decreased RV preload. At the same time, it increases the stress on the RV wall, leads to RV ischemia, again decreasing cardiac output. So all of this will eventually lead to decreased output from the LV, which will cause hypotension, which will decrease the perfusion pressure of both the left ventricle and the right ventricle, leading to shock stage. So what are the common causes that we can think about? So we can roughly divide it into causes that increase the afterload, that increase the preload, and also which affects the contractility of the right ventricle. So in the causes that can increase the afterload are massive pulmonary embolism, or a patient with acute carpulmonary, or a patient with primary pulmonary hypertension who presents with sepsis. Insufficient myocardial contractility, again septic cardiomyopathy can be a cause, but the classical right ventricular myocardial infarction, especially when there is an inferior STEMI. Excessive preloads can be because of valvular heart diseases, tricuspid regurgitation, or ventricular septal defects. So these are the typical examples that I just enumerated. So what are the mechanisms with which an RV dysfunction can happen? So because of the pro-inflammatory mediators which have got a cardiodepressant effect can lead to LV dysfunction, which can subsequently lead to RV dysfunction or thromboemboli, as I discussed earlier, and the mechanical ventilation is itself. Patients who are on mechanical ventilation, because of the increased intrathoracic pressure, because of the compression of the vessels, it puts additional load on the right ventricle. It increases the afterload. So ischemias, inferior STEMI, arrhythmias can also put it at a disadvantage, and hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction will significantly increase the afterload. These are some of the mechanisms with which in a compensated patient RV dysfunction can ensue. Again, ICU relevant conditions for us which can worsen the right ventricular failure are hypoxia, hypercapnia, acidosis, mechanical ventilation because of the increased intrathoracic pressure, decreases the RV preload, increases the afterload, results in diminished cardiac output if RV function was compromised before intubation. And beware, so whenever you treat a patient with right ventricular dysfunction or patients who have got compromised right ventricular function, mechanical ventilation can be life-threatening. Nearly about 20 to 30% of the patients will lead to cardiac arrest post-intubation. Always make sure that patient's blood pressure is adequately taken care before you proceed with intubation, especially in these patients. So the classical classification of pulmonary hypertension. So to make it simple, I have imagined the 5 classes. Imagine it as a mirror. One mirroring, it becomes a vessel wall. So it's a vessel, it's primarily related to the pulmonary vessels. So pulmonary arterial hypertension, class 1. Class 2, mirroring as left heart disease, whatever left heart diseases will come under class 2. 3 looks like lung, whatever. This is secondary to carpulmonale. 4, imagine a chair, pulmonary thromboembolism. 5, yes, other causes, sarcoid. So this is one of the easiest mnemonic to remember the classical causes. Coming to the signs and symptoms, because of the decreased forward flow, patients can develop respiratory distress. They can develop anorexia and nausea because of the venous engorgement, venous stasis, and decreased perfusion pressure to the abdominal organs. Weight gain because of fluid retention, hepatomegaly, and right-sided discomfort. Patients typically will present with pedal edema, ascites, and obviously raised JVP leading to distended neck veins. So if any of you by mistakenly place your stethoscope, you can hear increased intensity of the pulmonary component of the second heart zone. You can also hear holosystolic murmur because of the tricuspid regurgitation. So if you are keen on observing at bedside, you can see a prominent A wave because of the raised jugular venous pulse. This is classically in patients who have got pulmonary hypertension. You can also see a predominant V wave and then rapid XY descent in patients who have got tricuspid regurgitation. Liver will also be enlarged because of the congestion. You can see enlarged and pulsatile liver. So once the patient is in ICU, these are some of the basic monitoring that you do. You'll monitor rate and rhythm. Maintaining these patients on sinus rhythm is very important because it contributes significantly to the cardiac output. So invasive measures depending on the situation, temperature, like any other patients, you will have a central venous catheter. Coming to the laboratory values, we'll have natriuretic peptides, BNP levels, troponin in patients with acute MI, electrolytes and renal functions. Because of the passive venous congestion, perfusion pressure to the kidneys can decrease. You'll have to monitor the renal function test, liver functions, of course you're going to monitor. And echocardiography is one of the basic tools that will differentiate between various, because if you look at how the patient presents, so right ventricular failure is kind of a masquerader. So even patients who present with typical patient who is in ICU for long will have all these features like pedal edema, patients developing venous congestion. So all of these are typical features which are seen in any other patient. So echocardiography will play a crucial role. Of course, the gold standard is right heart catheterization. So what are the things that we can see in ECG? ECG will typically show right-sided strain, right bundle branch block with right axis deviation, with a predominant R wave in V1 and V2, and predominant S wave in V5 and V6. Of course, you can see the classical S1, Q3, T3 pattern in patients with acute PE. So here you can see predominant R wave in V1 and V2, predominant S wave in V6. You can see ST depression and T wave inversion in V1 to V4. So some of the features can be revealed in CT as well. Dilated pulmonary arteries. You can see dilated ventricles and the atria. Also, you can see in a contrasted CT scan that there is regurgitation of blood back into the hepatic veins. So coming to the transthoracic echocardiography. So these are the typical views which we can see, particularly for the RV. The parasternal short axis view is very helpful to look at the D-shaped septum. You can see the RV, how the contractile function on this parasternal long axis view. Of course, we have the apical four-chambered view. We can have modified views, particularly concentrating only on the right ventricle. And of course, classical, everyone's favorite IVC. So you can look at that in the subcostal view as well. So in the echocardiography, just by eyeballing, we can see what is the size of we can compare the size of the RV with the LV. So normally the ratio is about 2/3, 1/3. So 2/3 of the apical, the chamber will be occupied by the left ventricle, whereas 1/3 is by right ventricle. If the ratios change, if you feel LV and RV of same size, that means there is mild dilation of the RV. Of course, as the ratio changes, we can say that right ventricle is classically dilated. And as I said before, we can see the D-shaped left ventricular cavity, classically seen in parasternal short axis view. So these are some of the echocardiography findings that you can see in a patient with right ventricular dysfunction. So tricuspid regurgitation, you can see with a TR-jet. You can measure the right ventricular systolic pressure. You can make an estimate of the right ventricular systolic pressure by measuring the peak systolic velocity and applying the Bernoulli's theorem. 4 times the velocity square will give you approximation. If you add to this the right atrial pressure by measuring the IVC. If IVC is full and non-collapsing, you'll add approximately about 20. And if the IVC is full but it's collapsing between less than 50%, you can add up to 10. Okay, these are rough measures. Another classical the echocardiography finding that we do is tricuspid annular plane systolic excursion. When you put an M mode across the tricuspid annulus and measure the vertical distance. Beware, because whenever you try to measure, you often get confused measuring the slope. So tricuspid annular plane systolic excursion is the vertical distance, not the slope. Okay. If it's less than 1.7 centimeters, you can say that patient has got right ventricular dysfunction or right ventricular systolic dysfunction. And you can also measure the right ventricular and diastolic area and compare the ratio along with left ventricle. Another classical thing that can be measured is fractional area change. As discussed earlier, we can look at the septum. If the septum is D-shaped, if the septum is becoming D-shaped at systole, you can say it has pressure overload. If it's D-shaped in diastole, we can call it as volume overload states. So some of these features will be overlapping. So we can also add, we can differentiate between acute and chronic causes of right ventricular dysfunction by measuring the right ventricular thickness. If the right ventricular wall thickness, free wall thickness, if it's more than 5 millimeter, it is often because of chronic conditions. If you have tissue Doppler imaging, you can also measure the systolic velocity. So this is how it looks like if you are measuring. This is the vertical difference of view. Beware, I am repeating again, it's not the slope, it is a vertical distance. And the global standard, of course, is right heart catheterization. So coming to the management, we already know patient is in right ventricular failure. If it's a treatable cause, you proceed with a particular treatment. If it's a PE, you will always thrombolize. If it's an infarct, you will follow the protocol for the MI. If even along with this, you'll always look at whether there is excessive preload. If there is excessive preload, you use dialysis, or you can also use ultrafiltration. You may have to use. If there is excessive afterload, you try to decrease the conditions which increases the afterload, as discussed earlier. Hypoxia, preventing pulmonary vasoconstriction, hypoxic vasoconstriction, hypercarbia, acidemia, and abnormal lung volume. Beware, PEEP can affect lung. So the afterload on the RV both ways. If it's too low, because of the atelectasis, it increases the load on the right ventricle, increasing the afterload. If it's too high, because of the compression, it again increases the afterload. So it can be detrimental even if it's low or too high. So if you have a decreased perfusion, we can use various inotropes to increase the contractility. So if none of this works, of course we have ECMO. So I'll discuss further various factors as discussed earlier: reducing the afterload, optimizing preload, avoid hypoxia, hypercarbia, titrate PEEP appropriately, avoid high tidal volumes, and maintenance of sinus rhythm is very important. Volume optimization, of course we need to do a sequential echo. To reduce the preload, you can decrease the fluid intake, you can use diuretics, also we can use renal replacement therapies. Diuretics are better tolerated, especially these patients will have low blood pressure. Continuous infusion may be tolerated better, and it requires careful monitoring, because if you decrease the preload too much, these patients are very much preload dependent, so it can affect adversely, and this can also lead to metabolic alkalosis and hypokalemia, which may precipitate arrhythmias. Mechanical ventilation, low tidal volume ventilation, and adequate PEEP, which is neither too low or not too high. supplemental oxygen if the patient is not intubated to prevent hypoxic pulmonary vasoconstriction. And in patients with primary pulmonary arterial hypertension, there are various therapies that I discuss further, and specific therapies like surgical thromboendarterectomy in patients with chronic pulmonary thromboembolism, and patients with obstructive sleep apnea, because some of the patients with obesity can present with obstructive sleep apnea. Giving CPAP will be beneficial for them. So these are the agents which are traditionally used for the vasodilator therapy. Some of them are endothelin receptor antagonists, sildenafil, which is a phosphodiesterase 5 inhibitor, prostacyclin, and then analogs. Well, most of them in a patient with acute acute RV dysfunction, these may not be helpful. Of course, we can use inhaled nitric oxide as discussed earlier, even with patients who have got ERDS who are not responding, where the saturation is not bringing up. If you use inhaled nitric oxide, saturations will pick up after using inhaled nitric oxide because of its effect on the pulmonary vasculature, where it decreases the pulmonary right ventricular afterload. So these are some of the therapies which are probably useful for patients who are on OPD basis. Coming to the inotropic supports, there are no orally available inotropic supports specifically targeting the RV. Digoxin is not indicated. It induces the pulmonary vasoconstrictions and further worsens the pulmonary hypertension. And the risk of digoxin toxicity is quite high in the setting of hypoxemia and hypokalemia because of diuretics. So these are some of the agents that are useful. So we can use inotropes, milrinone, dobutamine, vasopressin. Milrinone, dobutamine, norepinephrine, and epinephrine will have got significant inotropic activity, thereby increasing the cardiac output. Milrinone and dobutamine will decrease both the pulmonary vascular resistance and the systemic vascular resistance. So beware for hypotension. So this might decrease the perfusion pressures. Whereas if you look at vasopressin, it doesn't have any effect on the pulmonary vasculature. It's a predominant systemic vasoconstrictor. So you can use along with any of them, or you can also use norepinephrine, but a classical norepinephrine works very well. But beware, it can increase the peripheral vascular resistance. And please do not use phenylephrine. It worsens the pulmonary vascular resistance significantly. So, as discussed earlier already, dobutamine at doses less than 5 mg per kg per minute can decrease the pulmonary vascular resistance. At higher doses, it causes tachycardia, systemic hypertension, and worsening volume. So, this is a brief management. If patient has got acute right heart failure, lung protective ventilation, avoiding high PEEP, treat the underlying diseases depending upon what the cause is, volume optimization. Patient has got volume overload, restriction of salt, measurement of daily weights, diuretics, and if none of these are working, we can eventually use renal replacement therapy. If the patient has got hypovolemia, we can give fluid challenges, of course, with sequential echo. If you want to give additional hemodynamic supports, we can use inotropes. And if none of these are working, we'll have to go with ECMO. So take home message. Right ventricle is a compliant structure, well suited to changes in volume, and it is vulnerable to increases in the afterload. Right ventricular failure is seen in a wide variety of critically ill patients in ICU, including pre-existing pulmonary hypertension, PE, sepsis, ERDS, or acute MI. Acute management involves optimizing preload, maximizing RV perfusion and contractility, at the same time decreasing the afterload. So probably you should use bedside ultrasonography sequentially to look at the causes of hypertension and look at how the patient is responding to the intervention. Thank you.
Thank you, sir.